So, hello everyone. Good to see so many people here today, and welcome. I'm Matt Camilleri. I'm an anaesthetist in the NHS. I'm also the lead for strategic partnerships of the National CLEAR programme and one of the co-founders of 33N. I'm going to be hosting today's webinar, which is the first in our three-part series of Beyond Pilots, exploring insights from AVT deployments across the NHS and delving into how organisations can move beyond piloting AVT to achieve kind of scaled, sustainable adoption and rollouts that will hopefully improve productivity and enhance care and staff's experience. So that's the whole series. A bit more about today's session. This is about people, and as I'm sure we're all aware, technology will tend to fail or succeed, hopefully, on the strength of the people that are working with it and using it. And today we'll discuss how to engage and support clinicians, empower staff when deploying AVT in the NHS. Drawing on the kind of live deployments we've been part of, I myself have done a couple. We'll discuss approaches to co-designing deployment, the engagement, the training, the building of trust, and a culture that enables confidence in AVT and make sure that it seamlessly integrates with workflows rather than works against people. We'll also look at the impact of AVT on morale, the retention of staff and their daily experience, and how technology, in terms of AI, needs to be considered more as a transformation tool, not just another way of doing the same kind of work that we have on a different platform. So just a quick reminder that today's webinar is being recorded so that we can share it afterwards on our website and our networks. And we'll start by taking a quick look at the speakers who we have today for the webinar. So go to the next slide, please, Demisha. Thank you. There's me at the top. I've already introduced myself. We have the privilege of having Dr. John Lynch, CCIO from NHS Suffolk and North East Essex, ICB. Dr. John Jeans, who's a consultant anaesthetist, the national lead for the CLEAR programme and CEO of 33N. Dr. Manpreet Singh, a consultant anaesthetist and lead for perioperative medicine at Royal Wolverhampton. And Tony Bell, the team manager and lead for pre-op assessment at East Lancashire Hospital's NHS Trust. We can look at what the agenda is for today, and what these wonderful speakers will be talking to. So the opening presentation is from John Jeans and talks about people first, the workforce culture and clinical engagement. Then we'll move on to Dr. John Lynch, the power of collaboration in digital adaptation across primary care. After that, Dr. Manpreet Singh will talk to us about the AVT rollout at Wolverhampton. And then finally, last but not least, Tony Bell will talk to us about the transformation that's been undertaken with nurse-led AVT rollout at East Lancs Hospital NHS Trust. And then at the end, we will have a Q&A, which I will chair. So we're not going to stop for questions during the talks or in between. So please put any questions in the chat or hold them tightly in until the Q&A, where we'll open up for hands and we'll get through as many of those as we can. But without further ado, I think we're going to hand over to John.
Thank you very much, Matt. And it's good to be see everyone here today and some friendly faces. What I'm going to do is just do a quick hop, skip, and a jump through the importance of people in the use of technology and the use of AI. So if we can, by introduction, my name's Dr. John Jeans. I'm a consultant anaesthetist at the Royal National Orthopaedic Hospital and lead the CLEAR programme nationally. So AVT in healthcare, I think everyone who's joined this call almost certainly is sold on the benefits of AVT in healthcare and what it can do. Just as a sort of overview of what the technology is, it's a couple of different bits of AI that are stitched together to listen to a conversation in natural language, take that conversation, build a transcript, take that transcript, turn it into a clinical record or a series of letters, as the case may be, and then use those outputs to reduce admin time and change the way that consultations are done between clinicians and patients. The benefits can be very substantial in terms of the reduction in administration time and boosting of productivity And we've had evidence that we'll see from colleagues later about the substantial productivity gains that can be realized. This technology very much is part of the long-term plan, and as everyone will be aware, there is a series of announcements coming out from NHS England nationally about the use of this technology and the governance and how it's going to be adopted safely. So I won't go into that in too much detail here. Safe to say that there will be some announcements over the coming, well, that have happened and will continue to happen over the coming days and weeks. That will give a lot of clarity and national steer as to how to get the most from this type of technology, and hopefully this work can contribute to that in a positive way. If we move on to the next slide, please. Before we go any further, I think the key learning that I've seen from this technology as it's evolved over the last 18 months is that the technology is amazing, but the people matter. If we don't engage with colleagues in a way that is effective, supportive, and collegial, we won't get the impact that we need. In the past, what we've seen with tech is that a lot of the time tech is dropped in organizations. And it's like, oh, you've got to crack on and use this. Now, in my trust, we're about to go live with an EPR. It's interesting to see the varying degrees of responses that colleagues have when the EPR is introduced. Some people very excited, some people a little bit scared, some people a bit apprehensive, some people a bit ambivalent. One of the interesting things about AVT is that when people start to use it, they can see all sorts of applications generally. But there's also some fear associated with that because there is a narrative out there in the world that AI is going to take jobs, AI is going to take my job. Now, I don't for 1 minute think that we are going to see widespread changes to the workforce within healthcare with the use of AVT. There's plenty of demand from patients and a lot of work to go around, but I do think it will change the way that we work, probably in a productive and positive manner for many of us, particularly in a clinical interaction, because you can have a much better conversation with the patient as a result. But I do think that it is important that we acknowledge that it is a change, and that when we are using AVT, we engage with people first. We move on to the next slide, please. Some of the points to make about this tech is that in clinical practice, small gains can translate into big improvements. But that does take time. It takes communication, collaboration, and confidence building in the different members of staff that are affected by the AVT workflow. And whilst it can remove admin, there does need to be changes into workflows on an individual department by department basis, so that we can see sustainable and tangible benefits. And I think that Manpreet and Tony will be able to talk to that in their particular professional areas. I also think to be important with AI and with clinicians using this kind of technology, it's really important that we use it safely. And it's important that people's fears or nerves around the use of technology are addressed as it is rolled out and utilized within different care settings. So I think this is more of just a sort of an ask from colleagues as we use AVT. It's really important that we do so in a structured, collegial and supportive manner, because if we don't, we won't get the impacts that we need for our colleagues, for our patients, and also for the taxpayer who funds our time. Move on to the next slide, please. What does bringing people on the journey mean? I mean, this stuff is all relatively self-evident, and I'm sure colleagues on the call will know this, but it is very important that this is done, not just sort of said. So engagement from the start is really important. Co-design, clinical involvement in leadership and listening to frontline staff is absolutely key, so that questions and concerns can be managed up front. One of the really impressive things about AVT is that it can be customized really easily. Now, there's some pros and some cons to that. The pros are that you can customize it to different workflows in various different care settings. The cons are that that does need to be done in a way, in a safe way. We will, in this series of webinars, talk about the safe deployment of AVT, so I won't go that into too much detail now. But the only thing to say here is that when we train staff to use tools, it's not really about that. There's a process of customizing the tool and then training staff to use it in a consistent manner after they've been past that customization. What that means is that people then become advocates, and it builds feedback loops that are very positive in the use of this kind of technology. Again, go on to the next slide, please. For AI and AVT to be truly embedded, it can't be seen as a digital product. It's got to be seen as part of clinical workflow. And so what that means is that there is very much a transformation piece as part of this, and supporting people to safely to think about how they are working, the potential impact of the tool, and then how they can change their practice utilizing the capabilities of the tool to be more not be more productive. That comes actually after a bit of time of using the tool and having confidence, but to communicate well in a safe manner with across different departments and disciplines. What I mean by that tangibly is that before you may have a workflow with AVT where you would document something in your paper record if you still have a paper record. Then after you document, you might then dictate into a letter, which would then go off to a secretary. What can happen with the tool is that you can have all of the things that you need all in one place at the same. So that's your clinical record and that's your letters. And then you can, if the tool's integrated, push those out to the relevant parts of the UPR, or copy and paste those into the relevant systems that you need if the tool's not integrated, to different colleagues. Instantly, you've saved time within your clinic, but also it saves time for the secretary because there's less editing, less transcribing to do. So but it's only when you customize the work for your workflow that you can work out how to do that at once. And when you do that well, the technology becomes part of the team and enhances the team working. Again, if we move on to the next slide, please. This technology is going to be challenging. AI as a whole, as it's used in the NHS, is going to be challenging to implement well because it is so different and because it is so new. And we as colleagues within our different roles within our organisation all see different sides of that challenge. The key thing for me is about the behaviours that we exhibit when confronted with implementing this technology. And sometimes we will have to, and utilising different types of behaviours for different types of situations is going to be really important. I think I was speaking to a colleague who's been a CCIO for several years now in a digital in the digital world for the last 10 to 15 years, and his reflection on the last 18 months was, we're not seeing anything different to implementing technology before, but we are seeing that we need to. We are seeing sort of more profound reactions, both of an excitement for adoption, but also some of the fears of adoption as well than we have with different kinds of technology in the past. And so I think we all need to up our game from a leadership perspective, so that we can do the most of this kind of technology. I'm conscious of time, so I'm going to skip through the last couple of slides. What does securing leadership by mean? We need, if we're going to, for this technology to work well, from the pilots that have been run, having good quality leadership, buying right from executive through to directorate and departmental management, right through to the front line is absolutely key. And if we have that alignment from board to ward, what we will do is we will get projects off the ground, pilots won't stall, and then it will enable scaling of technology as within organizations and across organizations. So the key that we need to do is we need to be empathic and collegial, but also firm is the wrong word, but sort of steadfast in the belief that the technology will deliver outcomes. And if we have that sort of steadfast, systematic approach to deploying this technology, we will get the impacts. Again, we move on to the next slide, please. So technology is an asset, or it should be an asset, and we have a unique opportunity to redefine digital adoption in the NHS. The success will very much depend upon the people, And if we invest in our people as much as in the tech, we will have a really, really positive outcome with this technology. And I'll stop there and hand over to the next speaker. Thank you very much for all of your time.
Thanks, John. And some of your thoughts there give me a plan to change my presentation, but I'll carry on. If I get interrupted, it's because I'm in the middle of a clinic and it will pop up. My EPR pops up in the middle and gets rid of the presentation. So I might flap around for a bit, but bear with me. We can discuss what we've been doing around ABT in Suffolk and North East Essex. Can we have the next slide, please? So my reflections on this is that really it's all about the culture within an organisation, and it's really is the key to success for any transformation process. Echoing what John has just said, strong leadership is absolutely essential to gain trust and include colleagues and give a shared sense of purpose. And strong communication is needed to engage clinicians early and often. Next slide, please. So my role as CCIO at SNE, Suffolk and North East Essex ICB, is to lead strategy with colleagues across primary, acute and community settings. It's to bring digital and transformation together, to mental health startups and accelerator programs, and with a focus on compliant and clinically driven innovation. And my core philosophy is that success means people and cultures first. Next slide, please. So within SNE, what we did is we set up a primary care automation and transformation group. So initially working with colleagues to write a primary care focused digital strategy, which included culture, training, use of existing systems, equity and innovation. So from that strategy, we formed a digital transformation group and inviting anyone in primary care with an interest to join. So general practice, general GPs, practice managers, digital transformation leads from primary care networks. We hold monthly meetings to discuss and showcase digital enablers, and we share learning opportunities and discuss the risks of AI, its governance, impact for patients. And then we have a yearly digital day where we bring innovations along and we innovators and they showcase, and we use that as a way to inspire teams and to take innovation forward within our ICB. Next slide, please. So as part of the meetings process, we identified ABT as a technology that we had thought had potential within primary care to reduce cognitive load, improve patient care, and enhance productivity. And we formed a subgroup which evaluated providers, and we looked at a number of parameters, including governance, cost, ease of implementation, and the support from the supplier. One challenge for us within Suffolk and North East Essex, within primary care particularly, was a lack of clinical safety officer support. So we have one clinical safety officer in the ICB and in primary care at this current time in Suffolk and North East Essex, which is me. And what we've done actually is we've identified that as an issue, and we've set up a training program for primary care clinicians who would like to be trained as clinical safety officers. We had a group because we had this lack of clinical safety officers, we had a group approach to compliance with the completion of the DTB 0160. And we did that with group training, information giving on the product, and we formed a group hazard workshop. And then once we'd had the workshop, we had a template which we shared with the practices, and they then tailored that to their own organisation. They then fed that back to me, and then as CSO, I signed it off. So following that, at the same time, a small team from the project group then supported the whole rollout process across practices. So in helping them with installing it and use with we also had a SOP which we shared, and they also the practices tailored that to their own processes within their systems. And we then set up an audit process for hallucinations and performance, and then a follow-up at 3 months, go live to reflect on where we've got to and any hazards that we hadn't identified, and to make sure that the governance process had needs and any changes that might be happening with that. The next slide, please. So this approach mimicked a process that we'd used before, where we'd automated patient registration. So we'd basically followed the same process, and by automating the registration, within 8 months we had an 80% take up of patient registration. 93,000 registrations in Suffolk North East Essex every year with the primary care, and we've saved 5 minutes per registration, which is approximately 6,000 hours of time saved. So by following the same process, we now have a way of introducing further innovations by following this process, the ground up approach. Next slide, please. So this is kind of a fast follower effect, really. So what we find is we've got sort of fast leaders and then followed by fast followers, and it's really been a truly collaborative process. We've emphasised the importance of compliance and understanding risk with these technologies, and we've also fostered continuous improvement and learning. It's allowed staff to sort of shape innovation rather than a top-down imposed approach, by creating a transformation group with shared ownership and purpose, we can continue to use this for further transformation. Next slide, please. So in terms of fast followers, we think GPs are quite competitive souls, and they're always looking at what's going on around the corner. And so they like to also share their sort of success stories with neighbouring practices and PCNs. And that's created a momentum of its own and encouraged more people to join this transformation process. What we've learned, I think, from this is that co-design and transparency build trust, that bottom-up engagement drives sustained use, multidisciplinary voices strengthen solutions, and finding a group or a forum or creating your own, which we did in this example, is kind of essential to derive similar engagement. Thanks. And next speaker.
Hi, thank you, John. Thank you. I would say thank you for inviting me to present our experience of AVT rollout at our Royal Wolverhampton Trust. And we rolled out in our pre-operative clinics a few months back. Next slide, please. So, as we all know, the NHS is under elective recovery pressures, and we try to look for the digital transformation in our pre-operative services, and try to look for the innovative ways so that we can improve the productivity and efficiency. And at the same time, while we were looking for the few challenges in our pre-operative clinics, CLEARnotes came at the right time from NHS England sponsored pilot. And we with due diligence of robust governance, we launched in March 2025. So the main aim was to explore and measure that how this technology will be useful in the real world, and to capture the benefits and to see what challenges with this technology. And from the very start, as myself as a perioperative medicine clinical lead for the trust, but I've got a dedicated time allocated to me as a digital development, as a clinical safety officer as well, and I've done a training of the clinical safety officer, and that really helped to how to implement the digital solutions in the clinical workflow, and what are the challenges with putting the digital systems in the clinical workflow. And this at the same time, when we launched CLEARnotes in our trust, we try to align with the trust use of AI policy, clinical practice framework, which was developed by our CCIO with experience of a NHS level for evaluation product a few years back. And from the outset of the start of this project, the safety of the digital solution, and that was the core of the start, and engaging the clinicians, that was key from the start as well. And we made a implementation plan before we launched this project. And it was a good collaborative relationship with CLEARnotes to designing a prompts for preoperative clinics, and then testing those prompts again and again to making it suitable for the launch. Next slide, please. So at the start, so we kept the aims of the project very clear, that we need to launch this project with all the safety components on it. And in terms of safety components, I would say the clinical safety documentation. We involved our IG teams doing DPIA and data ethics. And we developed the SOP and BCP for this, and we clearly signposted these documents on our Trust intranet website. Plus, we made it available in the clinics for the consultants to see and signpost. And before we launched this project, we did a baseline staff survey of the knowledge of AI, and what are the concerns with the use of AI in the clinical environment, which we'll share in the next few slides. And as I said previously, we co-designed our prompts with the CLEARnotes team, and we refined it as we go along before we launched the project. And once we deployed the project, our aim was clear, that to get the user experience and the regular feedback from the use of the system, which I echo with our previous speakers, and as we go along to understand and measure the quality of the output with the use of AVT in the preoperative clinics. Next slide, please. So once we launched this, so this slide shows the overall impact of using AVT in preoperative clinics. So it definitely shown the reduction in admin time. We increased the case load of work in one clinic we used to see 4 patients in one session clinic. So we managed to increase the workload from 4 to 5 patients. We did only in one clinic to see how it can be sustainable for the other clinics as well. But once we seen that this is doable, and this can be extrapolated to other clinics. In terms of admin burden, previously, before we launched AVT technology in our preoperative clinic, it was taking a time around 6 days from the point we used to do the clinic letters and to reaching to getting uploaded on our EPR system. That has been reduced from 6 days to 1.5 days. So that is substantial help in a reduction in the letter processing times. Few other things. Previously, some of the letters used to get outsourced if the admin support wasn't available. With the use of this technology, because the letters can be done there and then, so it helps in reduction in outsourcing letters, and that helps in the cost reduction as well. And the next is clinical acceptance and user improved significantly over the time. So we used to have a regular meetings with CLEARnotes team, initially every week, and then we moved on to the fortnightly, and now we meeting every monthly as well. So that did help in closing the loop feedback and improving the how we use the system. And based on the findings or the benefits from our preoperative clinics, now we are in a position to scale this up across the trust, which has been cleared by the senior executive team recently. Next slide, please. So that's very true that people is before the processes. And I mean, from the very start, as I mentioned, that we made a clear implementation plan. We took the baseline survey of the data. Once we deployed, we captured the data, and that was partly with the help of CLEARnotes team, and partly we were collecting the data locally as well from the users and from the patients as well. And this was led by me, and as I mentioned, that I got a dedicated time in my job plan to do the digital projects. And as a clinical safety officer, I can organize the various clinical safety meetings plus hazard meetings before deploying the digital projects. And so in terms of training and onboarding the clinicians, once we launched, so a few of the colleagues, they have some concerns before we launched CLEARnotes in March. But first of all, by doing a generic training and signposting them, plus after that we did a specific one-to-one training to those clinicians as well, to allay some anxieties or concerns in use of AI systems. And once we shown to them to see there's a robust governance in deploying the systems. So initially they were so we are 11 consultants in preoperative clinics. To start with, the 7 start using the system, and slowly, or within weeks, all the consultants are using the system. And as I previously mentioned, the feedback loops established very early from the start of the project. We did firstly as a weekly meetings, and then we moved on to the fortnightly and then monthly. Previously I mentioned that we did baseline survey of AI among our pre-op consultants, which it shows 71% they believe that AI would benefit healthcare, but 43% lacked understanding. So in terms of digital literacy and confidence building was central to the adoption for this project. And above all, adoption of appropriate governance processes before launching the AVT in the pre-op clinics. Next slide, please. Right, so top tips. I think I mentioned most of them previously. That I think the key part is also engaging the operational teams, which are managers, and the senior leadership team as well, to get a buy-in to use any digital system which can help in improving the productivity or efficiency. But obviously, once you launch the system, the continuous mirroring the data and learning from it, I think that really helps. And again, previously mentioned, feedback loops is quite important. And obviously developing some internal advocates, which we fortunately have quite a few, which help in driving the digital transformation in our trust. Next slide, please. So next steps. So as I mentioned, so we, based on the benefits we gain from pre-op clinics, we are scaling CLEARnotes across more services in the trust, and that has recently been approved by the senior executive team. And to share the learning across the ICS, we led this project. It was ICS-led project, but we led this project in the ICS among other hospitals, and to share our learning like we're doing today nationally. one of my colleagues, he presented the data recently in the Theatres conference at Manchester as well, and he presented the data in RCB organized, NHS England organized a roundtable conference as well. So ambition is for RWT to be a national leader for AVT and to produce some blueprint so that it can be used wide across the NHS. Thank you, and thank you for giving me the opportunity to share my experience. And I pass on to Tony.
Hello. Yeah, so I'm Tony. I am a preoperative assessment nurse by background. I am also the manager at East Lancs Teaching Hospital for preoperative assessment. I'm going to try not to repeat some of the stuff that's been said already about how we set it up. We've all had very similar processes about setting up securely and safely. It's more about our transformation of preoperative assessment as a whole. Next slide, please. So obviously, setting the scene for us in nurse-led preoperative assessment, anyone that does go through pre-assessment knows that there's lots and lots of paperwork, and with an EPR system, you spend your time facing the computer rather than your patients. So what we wanted to do was break them barriers down. We wanted to be able to converse with our patients again, as well as reducing our administrative burden, as well as obviously, from my point of view, increasing our productivity and obviously the trust point of view as well. So I came across CLEARnotes and involved my team in the process of getting CLEARnotes in. So they was involved right from the very beginning, which I think was benefit for us rolling it out. So they saw what the product could do and they liked it and wanted to help roll it out. Next slide, please. As I said, we applied to be part of it and we set some targeted outcomes. So to reduce the time in clinic, increase safety and consistency by standardising the documentation, and increasing productivity, reducing staff fatigue and improve morale and improve the patient experience. Obviously, we all do our job for the patients and that's what our aim is. Next slide, please. So the impact, we saw 40% productivity boost. So pre-CLEARnotes, we saw an average of 55 patients, and then post-CLEARnotes, an average of 63. Let's round that up. So that showed us a 14% productivity gain without increasing our nursing, and we did it by a lot of it by utilising our DNAs, what we would have had, so we could ring our patients up. Because the assessments took less time, so we had the opportunity to be able to do that. And also, we all know patients arrive by patient transport. We can't guarantee that they're on time, so we had the opportunity to see them patients too. Next slide, please. So since we've been using the CLEARnotes, our trust as a whole has maintained an 85% capped theatre utilisation. I think last week we were at 90% theatre utilisation and we was first top in the country. I think we've dropped a little bit. I think we're at 88%, but we maintained the 85% for the past 12 months near enough. Cancellation rate on the day has reduced from 10% to 7%, and this is really because of the documentation and the clear documentation we could get from CLEARnotes. And we have sustained the 14% productivity boost, which could help eliminate, obviously, our waiting lists. Next slide, please. So nurses are the champions. Like I said, my team was involved right from the very beginning in helping writing the prompt. As we were the first to try and do this, obviously we lived and breathed it for quite some time. We had the frustrations at the beginning of putting it in, but provided the real world feedback, which was corrected almost the same day by CLEARnotes. So the working collaborative together with my frontline nursing staff and CLEARnotes was really important. And practical improvements on how to enhance the usability of the actual feature itself. So we acted as core developers, creating a continuous feedback loop whilst maintaining the safety of obviously our assessments without you know, losing some of our patient engagement as well. Next slide, please. So for us, it's about a transformation, and it's not just a tool. So the AVT is an enabler and not a standalone solution. So the success depends on the alignment of our transformation goals. So what we've been able to do going forward, hopefully in the future, well, in the very short future, is using the AVT and changing the way we work using risk stratification of patients. We will then increase our productivity further. We can then go from seeing our 63 patients a day that we've got up to 90 patients a day. So that you can see the valuable of that without any additional staffing, without any additional funding. Build internal capacity for digital transformation. Because they've been part of it from the beginning, they're always open to the different transformation of the tool now and using it. Business change process, operational alignment. Our teams know, our speciality teams know and have been involved in how the process is, and it's being rolled out wider across our surgical division for our consultants. It's driven by data, so all you can see is the clinical activity, and you can see where enhancements and improvements and transformations need to take place, and the clinical engagement is vital. And obviously you can see the interaction with the patient is a lot more personalised from her point of view, and it's changed the way she works, and I don't think she'd be able to go back to how our old way of working either. Next slide, please. And that's it.
Great, thank you very much, Tony. Thank you to all the speakers. Some very insightful messaging there, lots of golden threads throughout all those talks as well, and top tips, so really good. That brings us on to the discussion and the Q&A section of the webinar. I'm going to kick things off and ask the whole panel, all our speakers, a question, which is, what have you found to be the most effective way to build early trust and buy-in from clinicians?
Oh, do you want me to go? Like I said in the presentation, for me, it was involving the frontline staff that are going to use it right from the very off, and setting out the clear expectations of what the potential is, and then obviously them being in part of it, helping create what it could look like and help the innovation going forward. That was, from my point of view, was the way to move it forward.
Yeah, so that co-development, co-design. Thank you, Tony. Manpreet?
Yeah, so I think it's bottom-up engagement that's key, involving the clinician at the very start, and if they have any concerns, so to signpost them and clear the concern at the very start. I think that is a key for, I think, getting the system off the ground safely.
Yeah, great, thank you. John?
Yeah, so demonstrating what it can do, because it's kind of a bit of a no-brainer when people see it. They're kind of really enthusiastic, and then involving them in the whole process, because they need to understand the risks and the governance, and enthusiasm can get people carried away. So you really need to kind of hang on a moment. You know, it's great, but it's not perfect. So we need to understand what are the risks so that you put it in the proper way. But when you show them what it can do, it kind of sells itself, I think.
Yeah, certainly gives them the reality of what they could be working with. Yeah, absolutely. Great, thank you all for that, very helpful. We've got one question in the chat. So what areas apart from planned procedures CLEARnotes already embedded in? Is CLEARnotes planned for deployment in general practice or other programs? John?
So we're using AVT. I'm not going to stick to CLEARnotes. We're using AVT extensively in primary care. It's I would say it's interesting because it's different from, say, the productivity gains. I think it's more a cognitive load gain because we've got 10 minutes, so you're not going to shave an awful lot of time off. But where it's really helpful is in those long, complicated consultations. It's brilliant for those. And also I use it in my emergency clinic a lot because it will generate the referral letter at the end, which is great. It saves a lot of time. So and it catches more than I would probably type. So it's quite a good sort of safety net as well. In terms of CLEARnotes across our system, we're just about to launch across musculoskeletal, mental health, and acute trust. So across a whole number of areas within SNEESH, we're just about to do that with CLEARnotes shortly.
Great, thank you. Yeah, I was just saying, I think there's go on, John. Go ahead.
Just to say specifically about general practice in primary care, that we are looking at that. We have IM1 integration, but I think we want to make sure that we've got the integration piece sorted completely first. I think, to John's point, I think it has significant gains in primary care. But our main focus right now is to ensure that the kinds of impacts that have been had in the initial sort of wave of work can be scaled, because I personally see this class of technology, and I think to John's point, it's not about the provider, it's about the class of technology, has been hugely impactful for colleagues and for patients. But I'm really keen that we do it well and do it right. And that is actually, I think, a little, to scale it well in primary care is potentially a little bit trickier than doing it within secondary care on a consistent basis. So I think that's kind of why we focus doing it on other clinical settings first. It's not to say it can't be done well in primary care, it doesn't have huge impact. But yeah, we're looking at general practice in due course. And if there are colleagues that are interested to have conversations about how to do it well and scale it well in an effective manner with appropriate governance and safety, then very, very keen to do that. So happy to have that conversation. But going to the point, doing it well, doing appropriate governance, appropriate safety, that's absolutely key. And it's a different landscape in primary care than in other larger NHS organisations. So yeah, thank you, Matt.
That's okay. I guess further to that kind of leads on to another question I had about how actually we've talked a lot about the clinicians, which is obviously extremely important, engaging of it. But when you are looking at rolling out wider, there's IT, there's all those people in those governance and safety elements, leadership within the organisations. How do we ensure that that multi-purpose, multidisciplinary engagement? What's the best way to look at that? Take that, John.
Was that to everyone? Was that to the whole panel?
It was to the whole panel. So you've just volunteered. There you go.
It's a big question, isn't it? I think it kind of, for me, I'm at risk of saying the same things that I've said again, but I think it answers the question reasonably well. I think going back to other John's point, well, to what everyone, Antonio said as well, that engagement process is absolutely key. It's slightly different in different clinical situations, and that nuance is really important. Having those local champions is absolutely key. But I think if you go down that route, if you go down with those premises, I think you can continue to get the impact sustainably. But I don't know, Tony or Ambridge or John, if you have anything to add to that.
Yeah, I agree, John. I think to sustain project, I think yes, the engaging the clinicians and I think getting the regular feedbacks from the teams, that is key as well. And mean, there will be always some challenges to start with, but I think just tackling the challenges. I mean, first of all thing, I mean, you need to plan ahead. These are the possible challenges, but some of the challenges they do come when the things come into the workflow processes. So those challenges can be, if that can be proactively tackled, I think that will help in sustaining the project for long duration. That's my thoughts.
Great, thank you everybody. We've got a few more questions in the chat, so I'm going to look to them. So there's a few about the pilot specifically. So I guess to anyone on the panel who wants to talk to their specific experience. So there's one about admin time. Have you found that there's admin time saved across staff disciplines, the clinicians, nurses, and admin? Where was the most time saved? There's one about did we capture patient experience separately for the pilots, and were there digital solutions already in place? So I don't know if you want to envelop those into your answers. That'd be really helpful.
I can come on that, Matt. So in terms of answering the first question, I mean, the admin time saved. So we clearly captured, sorry, the admin time saved in the clinics, in the pre-op consultant clinics. We did not launch in nursing clinics, so obviously we can't capture that. But in terms of admin, it did help because, as I showed in my slides, what used to be the process before launching AVT in our pre-op clinics was the consultant used to dictate, and that goes to the admin staff, and then they used to write, and then it comes back to the consultant to proofread and sign off. But with this, with AVT, one step is reduced. I mean, the consultant can do the letters there and then, and that need not to be done by the admin staff. So that obviously have saved the admin time in typing. Plus, we have captured that some of the letters used to go for outsourcing that has been reduced while we launched the system. In terms of patient experiences, I mean, in collaboration with IG, so we developed the patient leaflets so that we can give the information to the patients before we using the system, consenting. As such, capturing the patient experience while we're doing the system, we captured it offline, but nothing is much is documented. Few patients did document their feedback to us.
Cool, thank you, Manpreet. John's got his hand up next.
Yeah, just to echo that one, secretarial time's definitely been reduced. Secondly, if you've got anyone who has dyslexia, it's fantastic. They love it, really love it. We found that was something we hadn't anticipated, but then we've had that feedback. I thought, oh wow, great, okay. Thirdly, we spent quite a lot of time going back and forth with the DPO because they were quite concerned about the consent process. They felt that if the patient came into the consulting room and you just said, would you like to use, do you mind? That wasn't a reasonable consent because of the power imbalance. So like the previous speaker, we did a lot of work around patient information, patient informing, leaflets, website, and also informing the patient when they came into the room, and they really like it because they can then see on their NHS app the consultation. So they kind of feel more part of that process, and they get more of that one-to-one, that rather than seeing the doctor typing, they get that kind of focus on them. So the feedback, although we haven't formally assessed it, the anecdotal feedback is very positive from patients.
Great, thank you, John. Tony?
Yeah, from us, obviously, our admin time has helped us increase our productivity moving forward. But patient experience, obviously, at the start I said this is why we're doing it. We're doing a lot of it is for our patient experience. So we did do a patient survey, not at the beginning part around the consent, as everyone else has. We gave them the information leaflets, but we did a post one as well. So sometimes we get quite a lot of repeat people coming through pre-op that, you know, around some form of measures. So they have regular pre-op assessments. So we've asked quite a lot of them about how they found the difference using the EPR to using the CLEARnotes. And they love it. They can feel like they can just have a conversation with the nurse again. And some of the older generation like it as well, because obviously I know lots of older people come through all our services, and we think it's them that are going to be the ones that don't want to be involved in it, but they actually do like it. They like the fact that they can chat. They like the fact that they can interact with the peer person that is sat in front of them. And it doesn't really matter what they say, because the ABT solutions bring out the information that you need, which is really, really good for the patients. And the dictation solutions, we didn't have any dictation solutions. It was all face input computer. But I know within our surgery directorate, they do dictate, and a bit like Manpreet says with his service, it goes off to be typed up. So all that administrative burden will be alleviated, because it could be there and then and verified there and then as well.
Fantastic. Thank you, everyone, for those great answers. Hopefully that's been helpful to the people in the audience and the people who asked those questions. I think we can start to bring it to a close there. So very nearly done. Just to mention, we've got a second webinar as part of this series, which will look at safety and compliance. That's on Wednesday, the 12th of November. A third session will explore scaling pilot projects to wider adoption on Friday, the 14th of November. And details of registration links will be available if you want to join us. Any more information or questions, please get in touch at info@33n.co.uk, which will be on the next slide. Thank you. A massive thank you to the speakers for giving us their time and their insights, and for all of you for joining us as well. Thank you very much, and have a good day.